Good afternoon, everybody. It is just now 2 o'clock, and we are still waiting for several more folks to join, so bear with us. If you are a committee member, if you would please put your name in the chat, or if you are a committee member on the phone, please unmute yourself and let us know that you are here. We should be starting here in just a few moments. Thank you.
Hi, everyone. We'll get started in just a minute.
Again, to remind everybody that we should be starting in just a few minutes. If you are a committee member, please put your name in the chat. If you are a committee member on the phone, please unmute yourself and let us know that you are here. Jesse, I think I'm just waiting for one, if I can get one more committee member for a quorum, and then we should be good to go.
Great, thanks. Jennifer, did you have a question when we were getting started? Yeah. Oh, and you're on mute. Jennifer, if you're talking, you're on mute. Oh, okay.
There we go. My apologies, I have a new laptop. Yes, I didn't know if you wanted to add my name on for the committee to have a quorum, but that was a little bit ago.
Yes, thank you, Jennifer. Jesse, just give me one more moment and let me finalize my count here, but we should be good to go. Okay, and I see it's slowed down too with people joining. So Jesse, if you would go ahead, you can get started. We do have a quorum. Thank you.
Thank you. Thanks so much, Sharon. Welcome, everybody. Happy May. Welcome to the May Medical Care Advisory Committee, or MAC. It's great to see you all. And my name is Jessie Mandel. I'm the chair of this committee for just a few more meetings. And I'm also with Voices for Utah Children. So we are going to kick it off with just a quick reminder that this is an open meeting and it's open to anyone to participate. If you have any questions at any time or comments, please feel free to put them in the chat, raise your hand, come off mute. We hope that other people besides committee members will feel welcome to participate. And this is also a virtual meeting. We've made the decision as an executive committee to keep these meetings virtual until further notice. And hope everybody is doing well and managing to avoid this latest round of Omicron. So with that, we will look at the minutes for April and hope everybody's had a chance to review them. And when committee members would like to make a motion, we can approve the April minutes. So I'll take a motion to approve whenever a committee member is ready.
I'll make a motion. This is Kim Danzy.
Thanks, Kim. Anybody like to second that motion to approve the April minutes? They look good to
I'll
me.
second.
Great, thanks. Thank you so much. Great, all right. The minutes are approved for April, and now we have some time for the Department of Health and Human Services, or DHHS update. Tracy and Nate, are you here? Hi, Brian. I think they're going to be giving the update. I just can't tell if they are here.
Yeah, Jesse, if they haven't been able to join yet, we can come back to this item. Let me look at the list. I know one of them was planning on being here. I think Nate was going to join. And if he's not yet on, he's not yet on. And I don't see Tracy either. Could we come back to this item?
Yeah, definitely.
Thank you so much.
All right. So with that, we actually have a few minutes for some committee member updates, and also just a reminder that we'll have several positions opening up. Sharon, if you don't mind, can you just give us a quick update on committee members on some of the new and open positions, where things are there?
Sure. So we do have 3 vacancies currently. We have a provider representative for pharmacy, a provider representative for the community health centers, and then we also have 1 consumer representative as well currently open. Here coming up in the next couple of months, we'll have about 2 to 3 more vacancies as well. So if you have anybody that you would like to nominate, please email me. My email is at the bottom of the agenda, and we can get in touch with those nominations. Thank you.
Thanks, Sharon. And it sounds like the member with lived experience or community advocates is potentially being filled, but we don't have an update yet, right? That's being filled.
That is correct. Yes, that is correct. We are in the process of filling them, but they are not final as of yet.
Okay, that's great to know. And if anybody missed it, the last meeting, we have a new brochure to help get the word out to Medicaid members who might be interested in participating on the MAC. Here's that flyer. It's now on the MAC website. Thank you so much for putting it up there. And please feel free to share it, or if you have any feedback about that flyer, feel free to send it along to me as well. And with that, also wanted to just create a little time if there are any other committee member updates. This is just a time we hold on the agenda every month. If there are any updates from committee members, questions, things that you want to flag, or things you want to share, just want to make sure that what you see and know that's happening and going on in the work that you do, that there's time in the agenda every month to lift that up. So are there any committee member questions, updates, questions? Stephanie, yes. I was about to say questions twice, so you're
Yeah, I have a question. I'm just curious if there is any updates about how it's going, getting the word out about the Paxlovid or whatever it's called. Because I've heard that the demand is low, but the supply is high. And I'm just curious, like, how it's going with the plans and provider representatives getting members to know that that's an option that they have upon COVID infection.
Stephanie, I can attempt to answer part of the question, and then I would like to coordinate with the larger effort, which I haven't been involved in from the department level, on the communication strategies in the community to get the word out. Specific to Medicaid, we have been, continuing to inform our stakeholder partners on the availability of these medications. I think the fact is the coverage is open, I think what your question is more about is where to get the medicines. Is that correct?
Yes, I've heard, yeah, exactly. I've heard that there just seems to be a gap between what people know about where they can get it.
Yeah, I am going to have to research exactly how we've set up the communication strategy for that. I know that there is work being done to communicate and have pharmacies engaged in that work, and also get the access points available in where the access points in the community are. But I actually need to research to answer that question accurately for you. If there's, ACO partners on the call who want to speak to any work that you've done, we're happy to hear that at this time. But let me see if I can get that information and bring it back to answer your question, Stephanie.
Thank you.
Oh yeah, this is Brian. We'll just wait to hear what you bring back, Jen, if that's okay. I'm not aware of anything going on with the ACOs, so it's typically something. This is the medication or the.
Yes, it's an oral treatment option.
Okay,
It's
all
an
right.
oral treatment option. Yeah.
Okay.
Stephanie, let me get back to answer that question so I can accurately provide you the response. So.
Thank you. Yeah, just thinking about how we have that massive vaccine disparity, and that it seems like I've heard it's a really effective medication. So just would be awesome if we can make sure that Medicaid members have easy access to it. So thank you.
Thanks, Stephanie. Are there any other committee member updates, questions, events, anything anybody would like to share at this time? And Leah has a question in the chat. If somebody wants to answer that, Leah will get to that. Great. All right. Well, if actually, I'll just quickly open it up to the public. Any public updates, any questions that members of the public want to share? Okay, great. All right, well, you can always put stuff in the chat too. But from here, let's move on to our next agenda item around the One Utah Health Collaborative. Riley, are you here? Or there you are. Hi.
Yes, I'm here. Hi, Jesse.
Hi. So Riley Curtis with the University of Utah Health Plans is going to discuss the One Utah Health Collaborative, and I'll let you take it away, Riley.
Thanks, Jesse. Hopefully we won't have to take the entire 15 minutes. Let me see. Can you see this slide deck? Oh, it's coming up. Let's see. Okay. Can you see it? Okay. So I want to make sure if any of you have not seen or heard from this group already, that we had a chance to bring it to the MAC and that you all were made aware of the opportunities for input within this program. This deck was used for our patient design studio, but this in no way is a University of Utah Health initiative. This is the governor's initiative, but this is the truncated version that we use, so that's why I'm using this. So just a little background, Governor Cox named 13 community members, including myself, which were charged with creating a framework for the One Utah Health Collaborative. And this is really a statewide effort to reduce healthcare costs and improve equitable health outcomes, which was launched in November last year. And this group has been brought together to facilitate a collaborative process to set statewide health goals, and then to create a governance structure for a nonprofit that will be started later this summer, probably in the next month or so, which will have benchmarks and establish accountability measures with the goal of presenting its recommendations to the administration by July. Oh, sorry. Maybe not presenting, but that's when the nonprofit would start. And this nonprofit, it's really looking to find what are those small pilot projects that are happening in the healthcare fields that are improving health equity and access, or reducing healthcare costs, or just really innovative approaches to delivering healthcare. And how can this nonprofit that the governor's office is starting, how could it maybe look to scale some of those small pilots to impact more Utahns across the state? So I'm going to skip that. So really the guiding principles are collaboration, innovation, and accountability. And the goal is to build a collaborative solution to focus on health and not just healthcare. So Jesse and I went back and forth whether or not to run through these questions with this group, or to just make sure you knew where you could provide feedback on these questions. So I think we landed on, I've got a link that I can share with you all to provide feedback on your own time. We have held several stakeholder conversations, several of which were with healthcare institutions, healthcare payers. We've also had, I think, 3 or 4 community input meetings, one of which was in Spanish, for our nonprofit and community-based organizations to provide feedback on these questions. Just yesterday, we went to the 4th Street Clinic Community Advisory Board. So we're really trying to get as broad of feedback as we can on these 5 questions. I know that several groups like OUCH and Utah Health Policy Project have kind of like taken several organizations' comments and then fed them into the governor's office. But again, just wanted to make sure that if you haven't heard of this, that you have the opportunity to provide input. So I am going to send 3 links into the chat, and hopefully the links work. And that is all I have, Jesse.
Riley, one thing just for MAC members to know, we were going to put together some comments as the MAC committee. We talked about doing that. So for MAC members, of course, you can send comments through that chat individually, or through that link individually, but I'll also be following up after this meeting, and we'll work on putting together some committee-wide comments. So we'll send those to you as well.
That would be great. I would recommend, I think that they really wanted to wrap up, they wanted us to wrap up the feedback last week. But so the sooner the better, and I think that they'll definitely make an exception for the MAC and MAC members. So please do compile your thoughts, but please do so as soon as possible.
And Stephanie, I see you have your hand raised. Actually, just really quickly, Riley, like for this committee, are there what are you looking for from the MAC? I mean, that is specific to the work around Medicaid. Is there anything in particular that you want to get as a MAC body?
I mean, it's the sky is the limit, I think. So it's really what the MAC's priorities would be. Things that you're already working on, I think, align nicely to the work that we're doing here. But we all know Medicaid is such a large payer in this field, and there's also a lot of innovative things that can happen in the Medicaid realm. So I think use it as a platform for your message and your vision for Medicaid and CHIP.
Stephanie, is your hand raised still? Okay.
Yeah, it is. Yeah.
Go easy on me, Stephanie.
Sorry, what was that, Riley?
I said go easy on me, Stephanie.
I will. My question is just like, how much do we know about like so in those patient feedback groups that you've conducted, how many were actually patients that receive Medicaid and CHIP?
That's a really great question. I don't think that we track that, but what I can tell you is that we have given this presentation and had a dialogue with Intermountain Healthcare's Patient Design Studio, with University of Utah Healthcare's Patient Design Studio. And we didn't get in time to do Primary Children's Design Studio, but the resources and the intake forms were sent out to the Primary Children's Design Studio. So we have tried to reach out to patients specific, not just nonprofits.
Thank you. But you don't have the specific numbers on what they're
Breakdown.
kind of grouped together in like the marketing material in a way that I just think kind of stretches some meanings of words. I mean, patient advocates, for example, like I saw the former Governor Levitt was listed as a patient advocate. I mean, things like that just kind of seem a little bit weird. So that's my easy word for you. I think words should have meanings, and I just think that like I'm not saying the percentage of different things. It's just like the lack of, whenever I hear that it's going to be super accountable to the public and then there isn't some of those specifics, it just doesn't really show that kind of accountability and clarity and transparency. So I would just like ask that things are more clearly, communicated about like how these ideas come about. I mean, we know that industry folks were approached a lot sooner than any patient perspective. So I do just think, and that's fine. It's just like, I don't know.
They were all approached at the same time. So there's other slides that, since this was the truncated version, but it shows that all of those conversations were happening all at the same time. So we've really been doing, over the last 2 months, it's been the healthcare systems, the healthcare payers, businesses, community, and these patient design studios. It's all been in the same time frame to inform the goals of the nonprofit that's going to be formed. And I think one other thing that I failed to mention was that on those 13 individuals that I mentioned that are helping to kind of guide this work, we have Miss Betty Sawyer and Miss Areta Topola, and who are community health workers that are on the planning process as well. So they have really done their best, I think, to try to be inclusive early on in the process.
No, and I appreciate that. I guess I meant before it passed. I mean, I just know that
Oh,
this
yes,
came about
okay.
in the fall. So I get it. Like, I totally get it. I appreciate, the complexities of all of it. Just saying that, like, I mean, I was told that it was approached, back in the fall. That's fine. I just think like that kind of honesty just helps with trust, right? Like that's a huge thing that I care about. And I just feel like the lack of transparency and accountability makes it really hard for people to just like know what they can actually expect. I mean, if things are actually going to change or if this is just, fun marketing things. I don't know. But I do appreciate that, I appreciate the groups that have tried to come together to speak up, and just would be interested in some more specifics about how we're getting patient feedback in a different way than just through nonprofits. Thank you though, Riley. I hope that wasn't too harsh.
Thanks, Stephanie. And then the 3 links that I put in the chat. So the one is to answer the 5 questions that I flashed on the screen. The second is just broader feedback on like goals, priority areas, and accountability measures. And then the third link is if you're aware of, or if you're in your organizations are wanting to share information about innovative pilots that you're doing or innovative healthcare approaches, you're welcome to share that as well. And a design studio, Jesse, is it's really like our patient advisory groups. It's just a different name for them.
Thanks, Riley. Well, we're, as a MAC, I think it would be helpful we'll work on it quickly, but I know Michael Hales couldn't be here today either. But I think it would be helpful to share some like Medicaid Advisory Committee specific feedback. And so we'll be reaching out committee members, but definitely, please feel free to fill that out if you have other. Oh, Michael, you're here. I'm sorry.
I am. I just wanted to be acknowledged so that people wouldn't be surprised with the meeting minutes later. No comments though.
Okay. You can definitely share comments. That was not meant to silence you. I missed you in the lineup, so my apologies. Jennifer?
Hi, yes, and I just, Stephanie, this isn't directly addressing your question around Medicaid member input on the health collaborative specifically, but I do want you to know Medicaid is like on a working group, a couple different working groups within the collaborative, and there is a Medicaid specific meeting that is next week where we will be meeting to specifically address Medicaid, stakeholder input. And there will be individuals present from our ACOs and our prepaid mental health plans who could contribute to that. And certainly we could hold a different one as well. And Michael, Jesse, we could talk about what this could look like on the MAC side as well. But Dr. Michelle Hoffman is one of the chairs of this group, and she's helping lead the Medicaid stakeholder group, and then I'm co-chairing that. So we do have Medicaid representation, Stephanie, and to get input from the MAC would be helpful as well. We'd love to gather input and bring it into the Health Collaborative Executive Committee. So
Thanks for that, Jennifer. So then on that Medicaid specific stakeholder group, is the stakeholders just like the public sector, or is it also the public sector and the private groups that get contracts and are patient? Yeah, I'm just trying to understand how.
Yeah, it's a good question. For this particular Medicaid meeting, it's focused on our ACO and prepaid mental health plan stakeholders. But I would like to take back and work with the group on meeting the needs of what you're talking about as well. So Riley, if that's something we want to look at what's been done, and Jesse, I'm happy to speak with you and Stephanie and Michael about what your ideas might be. Now's the time to gather these ideas and put them forth. So I appreciate your input on this, Stephanie, and want to be sensitive to what you're asking for as well and making sure we're addressing that. So.
Thanks, Jennifer. Yeah, that would be great if we could circle back. I know the timing is tight, but happy to quickly talk to you about that later this week or next week as well. Great. Okay, well, Riley, thank you for being here and presenting. And we'll be in touch. We'll follow up with you with additional materials. Next on our agenda, before we move to you, Jeff, I do just want to pause because I guess I'm missing people that might be in the chat. Have Nate or Tracy are they here, and do they want to provide an update on the DHHS merger? If they are, or if you are here, Nate or Tracy, please speak. Okay, it looks like they are not. All right. Sharon, if you see them pop up, will you let me know? Because that way that's great. Thank you.
Yes,
okay.
I certainly will. Thanks, Jesse. They're not on quite yet. So
okay.
Thank you.
No worries. Thank you. Okay, Jeff Amers, and hand it over to you to give an update on the exciting PHE Unwinding news.
Sure, happy to do it. It's been an interesting week for us. When last we met, we had a really good discussion, I think, about the public health emergency and how it might be coming soon to a close. We anticipated that we would be seeing something with a 60-day notification in it, either last Friday or this Monday at the latest. And obviously that has not materialized. Instead, we've seen some other banter going back and forth, and it may be that we're looking at another extension of the PHE. As a matter of fact, at this point, in order to give the 60 days, they'd have to at least extend it a little bit so they could give us the 60-day notification. So it looks as if we are not yet to the point of starting to unwind the regulation, which would mean starting to go back and look at all the Medicaid cases and really sift through and return eligibility to normal. So we are still currently, April 16th was the last time it was updated, which takes us through July 15th. We could see another extension. They don't have to be 90 days, but they have generally been 90 days, and that's what we're likely to see next. If you're better at reading those tea leaves, we'd love to hear your opinions on what might happen next. So it just puts us back into the hurry up and wait phase. The good news to that is that we were able to move our eligibility system EREP into the cloud. It's into some cloud computing now, and that went fairly successfully over the last weekend. That now allows us to start doing some of the programming efforts we need to prepare ourselves for what that eventual unwind will look like. We were able to make some progress, though. We did mail out one of our letters. I went out to the COVID-19 group. This is the group of folks that are able to get testing and testing-related services, and now also can get vaccination and vaccine-related services. So that's wonderful to at least notify them of the increase in their benefits. And at the same time, we inform them that their benefits do end when the PHE ends. And so that they're aware of that and can now raise their hand if they want to. If they would like us to take a look at other Medicaid programs, we can do so. So that notice went out. It went out to roughly 12,000 people total, because that group has continued to grow. And then I thought I'd give you a quick update on the numbers because they do change month to month. We are now looking at 116,000 cases that are being held open in various ways, which means roughly 203,000 members. That's up about 7,000 from the last time we spoke. So at least last month we had about a 7,000 increase. And I'll try to report that each month as we go, just to give you an idea of how many cases we're looking at where we just don't know their eligibility. We don't know if they're eligible or not.
Jeff, say that again. 116,000 cases.
203,000 members.
203,000 members. Thanks.
You bet. Outstanding items for us, we're anxiously watching what other states are doing too. I mean, that's obviously important to us to see if we're about the right speed with everybody else. Colorado this last week launched their own webpage talking about the public health emergency. Our intent had been to launch ours very soon after our 60-day notification, which again, we thought would be last week. So we may be able to launch that webpage a little bit sooner, we would put up the slideshow that you saw last time. We'd put up the plan from last time, and we would start as soon as we could to put up some of the early metrics, the baseline metrics of what's happening today at Workforce Services. So that could be coming to a webpage near you soon. We'll keep you up to date where that is and try to make sure that you're aware when that does launch. In the meantime, our next steps are to continue planning. There's a lot of materials to now update because we had kind of guessed on that July date. We'll be pushing that to maybe guessing on an October date, or we'll guess on a January date. We'll find a new time to guess. And it does allow us, again, to get the system ready to go. And by getting the system ready to go, we think we'll have a better chance to prepare our workers, the eligibility workers, and get their training done a little bit better. There's a question about where do we find the unwinding plan. I think we sent it out to this group last time via email. I'm happy to send it to anybody that did not get a copy of that. And again, we'll hopefully get that on a web page where you can see it anytime you want. And we do continue to update it as things change. If we get new information, we try to add that to that document so that it's staying living and breathing and up to date as we can. As far as the dashboard, I did want to mention one little note about the dashboard. We had some great work done on that. We're still pulling together all the data. We've had to make some new data requests of our friends at Workforce Services to populate all that information. But we are making progress. It's incremental right now, but it is getting better. And as soon as that is ready to go, we do feel like we could at least, again, launch that baseline data and are excited to share that with the group. So I'll let me pause and take any questions. And I think there's ACO's plan on there as well. So I'll pause. Jesse.
Yeah, I just had a question about the dashboard. I don't know if Marissa's on here too, because this was something that we started to touch on last month, but I just wanted to revisit is the question around what will be included in the dashboard. And I know we'd had a little discussion around looking at some of the metrics that had not been included, specifically around, in addition to call volume, if metrics like call wait time and call abandonment rates could be included in the dashboard. And I just wanted to see if there have been any more conversation there and any updates about that.
I'm not seeing his name on the, is anyone from DWS in the meeting with us today? I'm not seeing any names I recognize. It's hard to answer for them. The best I can do is that I know that our senior leadership is talking to their senior leadership and that those discussions continue. I'm sure that's an item that we can take back and talk to them again about. As you heard in the last meeting, there was some sensitivity to focusing on the wrong area. And the focus seems to be that the DWS wants to focus on making sure that we're getting through the cases. And I think they're worried about having to chase other metrics should those be out there. That's what they have been saying to this point.
Okay. Yeah, I'd like to just make sure that that's something that we look more into. I think my concern is that if we don't have those additional points, then we're not going to be having a complete picture around what's happening and how we can best make sure that we're supporting consumers and also making sure that we're advocating on that the needs of both the DOH and DWS are being met. It definitely shows that there's a really high volume, but there's also a lot of people that we might need some additional support or might have additional questions that aren't being met. So I think the more information that we have that we can all look at together, I think will definitely support this process moving forward in a smoother, more transparent way. So I just really want to encourage those additional data points to be shared in recognizing that, if they're already available. I think that's, we don't want you to have to chase after and create new ones, but if they are there, I think it makes sense to include those in the dashboard. So just want to lift that piece up.
So we'll make sure to pass that request along, and it's not new data for us. We are sharing that same type of data with CMS, so it's data that's available, I believe.
Great. Thanks, Jeff. All right, well, we can bring that up next meeting as well. Or if you hear anything in the meantime, please keep us posted.
Happy to do so.
Great. Well, okay, then that's my question. Are there any other questions before you turn it over to ACOs around the unwinding? Okay.
And I'm not sure if there was someone designated for the ACOs specifically. I'm not quite sure of the agenda item itself.
Hey, Jeff, I think we were just going to each, excuse me, talk about our efforts individually because they're not all the same.
Wonderful. We have the famous Julie Ewing on the phone.
So I can just jump in here and help with, give you an update on what we're doing with Help the U. So just kind of as a reminder, the Department of Health did ask us not to go out and do big campaigns or anything along those lines, just because they don't want us to overwhelm DWS staff right now or cause, potentially cause a panic when the public health emergency, keeps looking like it's getting extended. But we have undertaken some efforts, at least on the Help the U side. So we've done a Facebook post on our Facebook page, both the English version and the Spanish version, to tell folks about the unwinding of the public health emergency. We figured we could probably be in a better position, the Department of Health, to try to get these communications out in different languages. So that's really where we've put a lot of our focus in. So we've put this in our member newsletter in both English, Arabic, Spanish, and Somali that go out. We've also have a lot of meetings, not a lot of meetings, but we have various meetings that we have actually in person with our members for various reasons. And so we communicate that to them, and these meetings are both in English and Spanish. We've been also sending letters and emails on a monthly basis based off of the report that we get from the state. So in April and May, we get a report from the state telling us when people's reviews are due. And so for people whose reviews were due in April and May, we just sent them a letter saying, hey, go do your reviews with DWS. And hopefully that, helps support the vision without overwhelming DWS. And we do those again in the native languages of folks, English, Spanish, Arabic, and Somali. In addition to this, we've also done presentations to our University of Utah hospitals, clinic, and staff, so that providers are aware and can help us convey the messages needed. And then we're also planning at the university, they have television screens that loop messages, and we're going to put some information up there with our providers. So that's what Help the U's done so far.
And the main message being, make sure your information is up to date and check your reviews when you say like put information up. Okay, thanks.
This is Brian. I was going to wait till last just to see if there were other ACOs that wanted to join in, but are there any others?
Well, I'll definitely
select, health choice.
Yeah, select.
Go ahead.
Sorry, we can definitely go next if you want. So we've also taken that eligibility file that was talked about there, and we send a postcard out for each one of those, and we get those on a monthly basis, so it is spread out. It's not going to be all at once, but what it is going to, we get those about 60 days in advance of when they're supposed to go through their renewal, and so we're getting that out, and then we have a system flag in our that the customer service has, that when people call in and we know they're inside of that 60 days, our customer service will ask them about whether or not their address is updated. We don't, so if anybody calls in that time frame, we can make sure that's updated. We have taken the flyer that the state has produced, and we've distributed that out to a bunch of different places like the Alliance Community Services, Southwest Community Center, Centro Hispano, Suazo Center, Urban India, a bunch of places. We did put it in the Consulate of Mexico as well, and did a brief video in Spanish about that, just basically reading that in Spanish. We have a number of other areas that we put that out in our provider newsletters, and our medical home teams are looking at that to work with those members that are affected. We also have done some social media posts out there. In the future, we're looking to do put it in our member newsletter, and we are going to put that out as a direct mail to all of our Medicaid members, although we're going to kind of try to do it methodically and put it over send those out in batches so that we don't overflow DWS with a lot of traffic there. We're going to include it in our member handbooks and community related events that we go to. The state is also going to give us a closure list, which is we'll get that about 6 to 8 days before people actually term, and we are going to look at some specific messaging for the two groups that we see there. The ones who no longer qualify, we'll hopefully try to direct them over to the marketplace so that they can look to get coverage there if that's the option that they have. And then individuals who don't complete the renewal process, we're looking at trying to reach out to them in a number of different ways. We're looking at predictive modeling to look at high-risk individuals and people that maybe have literacy problems. We have some access to some of that data that we might be able to prioritize calling them in person, but we'll have some robocalls that'll probably go out and some direct mailers to go out to help try to get those people to get through the redetermination process. And then, and that's really kind of in a nutshell what we're doing. So I don't know if there's any questions there.
Jesse, when you say that you're getting a list and then contacting people who have a pending closure, are you encouraging to, like, because they still have time? I guess I'm just wondering how do you?
Well, some of them we get that just maybe like a week before they are termed. We can contact them after they're termed for a certain time period if they're our own members, because if they do come back on, they'll just come back right on to Select Health. So we will during the next 30 to 60 days try to work with them to get through that redetermination process, and so that's kind of the big part there. Go ahead.
You said something about predictive modeling is going to help you identify high risk. What company, like what vendor are you using, and what kind of algorithm are you using
we have an agreement with a company called Decision Point, and they really look at a lot of things like if you've been to the hospital in the last so many days, what kind of claims you've had in the last year. If you're somebody that's like a high utilizer or that has that is kind of shows to be more vulnerable, then they up the priority list on that. And then also, they do look into some demographic things that, like communities that typically have a lower literacy rate and that kind of thing. So they look at a number of things. I don't know what the complete secret sauce is that they have in their lists, but but it is weighted towards health acuity and some other demographic things that would typically be kind of a burden for them to go through that process. Does that help?
A little bit. Do patients know that their data is being used by this other vendor?
I'm not sure really how to answer that question. We typically have a lot of things that go. We use this for our care management as well. So we look to reach out to members who maybe need care management, and so that same company we use it for that purpose as well. I don't know all the ins and outs of that part of your question. So but if you would like, we could talk. I could connect you with some people that could answer further questions on that.
Yeah, we can connect later. Thank you.
Any other questions?
Jesse, I'd be interested in learning about that too, if so we can maybe follow up afterwards. Okay.
All right. It's kind of a new thing that we're looking at. It's kind of a trend to try to get people the need that they need, the help that they need.
We have health choice on. If not.
And Brian, I'll say, sorry to because you're going last. Sorry. In the interest of time, if there's things that have, you don't,
Nope.
you know. Need to,
Nope. Really, all we do is we're looking at those lists the state give us and working those because really that's where the rubber meets the road, right? That's where we can make the most impact is on those individuals. But we want to be careful that we're not saying that your eligibility is is in jeopardy or anything like that. It's just until the PHE is over, you'll still be eligible, but we do need to get you redetermined. So yeah. So yeah, in interest of time, let's move on.
Okay, thanks, Brian. Sorry if I cut you super short, but thanks.
You're good. Nope.
And actually, I just have one quick final question, Jeff, with the plans. I think Stephanie, you brought this up once before too. If there's an address update that comes from a provider or insurance plan, how does that move over to your side or to the?
Sure. Yeah. So it can come a lot of different ways. We have two different groups that can update addresses now. So if you are contacting what's called a health program representative, these are state employees that work here. Well, I'm in the building, but they work for this organization. Used to be in the building. They can take that address change and make that directly in the system, which is really pretty neat that they can do that now, and can also order a new card if that's an issue that they have. You can also contact DWS directly to make those changes. The health plans work with us. They have a file essentially, or they contact us on individual cases to make sure those addresses are updated.
Thanks, Jeff.
You bet.
Thanks for the update. And so the unwinding plan will be, that's a living document that's going out, so we can peruse that. But will that be, is that a PDF file or is that a Google Doc that's being updated? The unwinding document.
Oh, the unwinding document, it is a Google Doc. We can put it out in the PDF format probably for you.
No. It's just when you mentioned it was a living document, I just wanted to make sure.
It is updated. So you'll see updates, and we do keep the last update date on there, so you can see the last time we changed anything.
Okay. Terrific. Thanks.
You bet.
Thank you. Okay, great. Well, with that, let's jump back in the agenda to the second item with the DHHS, Department of Health and Human Services update. Nate, I'll hand it over to you to give the DHHS update. There's a lot of H's. HHS.
A lot of H's. Feels that way sometimes. So thank you for the opportunity to come and talk to you today. Following up on the unwinding plan, one of the issues that we've been working through is our plan is set up, or we've been talking about a July 15th date. But as we know, that federal DHHS, CMS, has indicated that they'll give us 60 days notice before terminating. And so it looks like that date will be moving out to some other date. And that gives us a chance to review some of these plans. One of the major issues that was an issue for DWS related to this date is that they've been moving the EREP system to the cloud, to AWS, and that has sucked up a significant amount of their bandwidth. And so if this date moves out to some other date, let's say October or January, they won't be facing that same constraint. And so that may give us some opportunities to do some things a little bit differently. So we'll pay attention. We'll see what comes up next, see what the next extension looks like. We're expecting that there will be one now at some point, since we passed the 60-day marker and have not received notice that the federal PHE is ending. So just to keep that in mind as we talk about unwinding plans, that for better or worse, it is a continually moving target and the ball has not stopped bouncing yet. Related to the merger, we always, as we talk about HHS, DHHS, it's still coming into fruition. And so just a reminder, let me pop up on the screen our org structure. And I know we've walked through this multiple times, but just a reminder about where we're going as a combined agency, that we have Tracy Gruber as the executive director. We have 4 major sections that we will be operating out of. Those are those blue boxes. We have an executive medical director, operations section, a healthcare administration section, and a community health and wellbeing section. This information is all on our website, HHHS. I just did too many H's too, hhsplan.utah.gov. And it has, as you go through this plan, there's actually multiple org charts here with greater details. Here's one with all of our lovely names on it. And then it actually goes by individual section. It gives you a little, if you wanted to just see that section by itself, and you can see the names of the leaders in each of those sections. So just wanted to remind you on that. July 1 is still our official merge date. We have actually moved through a significant amount of our merger operations. The operations section, which has a lot of different units that work across the department, like audit, like hearings, like licensing, have already been integrated into single units. And our leadership structure and reporting structure has also now moved into this DHHS structure. So in large part, we are operating as DHHS right now. With the official legal merger will occur on July 1, but in practice, many of the things we're doing are already in this structure. One of the things that we are working on in this structure is related to our strategic plan and our values related to that. And while we are not ready to release those yet publicly, we're still working through those. I thought it might be helpful to give you an idea of some of the draft concepts we're working on. In our new structure, we're looking at results-based accountability as the model we're using as we talk about our strategic plan. And in that model, we identify a population outcome. And right now, and again, this is all draft, but I'm sharing with you just to give you a concept. Our draft idea is that all Utahns have fair and equitable opportunities to be healthy and safe. Then we identify population indicators that will help us be able to see whether or not that outcome's occurring. Things that we're considering using are rates of abuse and neglect, life expectancy at birth. If you're familiar with the Health Improvement Index, using that as a potential measure, and other indicators of disparities. Then to help support us along this outcome measure, we identify specific strategies that we're working at. And here are some of our draft thoughts about strategies that we may be adopting as a department. That we would ensure quality care services and programs are accessible where and when they're needed. That we would foster safe and supportive environments. That we would improve health outcomes, both physical and mental. That we'd create a high quality and efficient department, and that we would build public trust in DHHS. And then within each of those strategic goals that we would have or strategies that we would identify individual measures that would help us know if we're moving along that way. And so maybe, I'm just seeing if I can pick one real quick, let's talk about potentially strategy number 3, improving health outcomes, both physical and mental. Potential things that we could measure, rates of suicide deaths, rates of obesity and related chronic conditions, drug overdose deaths, immunization rates are some things that potentially could be measuring related to that strategy. So as mentioned, that's a work in progress for us right now. We're working through at the leadership level and also at the division levels to see if these are the right strategies and measures that we might use to guide the department and to see if we're moving forward in the right direction. But I thought it might just be helpful to give a brief overview of that part of our work. Let me pause there and just see if there's any questions about the merger or about the direction of DHHS, and then I'll provide just some brief information about what we're doing related to the infant formula shortage, which I know is a large issue right now across the state.
Yeah, I have a question. I'll just take my own hand down. So I'm on the org chart, and I probably missed this earlier, but the fact that Medicaid and the state hospital, it seems like it's a huge area. And I guess I understand kind of the need to not like silo Medicaid. At the same time, I guess I'm concerned about the size of that group or whatever, you know, that part of the org chart and what it means for the ability of just, for Medicaid operations overall. So I don't know what kind of, if you have thoughts about that, but that's just one thing that I'm curious about.
Yeah, I think that's a great point. And it is a very large division. So this is in the Integrated Healthcare Division. Jen Strohecker is the division director over this area. And it is big. Medicaid alone is, you know, probably the largest piece of the state budget, maybe right after public education, if it hasn't passed public education yet. And then to add to that, as you mentioned, a very large institution, which has, and I should know that number better, but 600 to 700 staff members, and has the 24/7 responsibility for the individuals that are residents in that facility. And there it is. So acknowledging that is a large responsibility. Part of the reason why we wanted to bring those groups together, we do think, and as we've talked a lot about this, we do think there are some opportunities in our state to do a better job integrating behavioral health care with physical health care. And so we've had extensive discussions, both amongst our leadership group, with public groups, with the Division of Substance Abuse and Mental Health as it was constructed before, about the best way to structure this group. And we decided that if we really wanted to create some of those synergies, that our best way of doing that was bringing these units together under a single division director. We know that span of control is large. There's, as listed here, we have several three assistant directors to help support in that work. But we saw that as our best opportunity to try to integrate those financing, provider requirements, member services, customer experience. And so we're going to push forward in that model and see if we can be able to take advantage of the fact that we're working out of a single division to see if we can better integrate those services.
Hi, Nate.
Hello.
Hi. I'm curious. I believe I asked this a couple of weeks ago, but I'm wondering if y'all are able to talk about how like promoting the health and like looking at health outcomes from like a health equity perspective for like this division. I know that in the past, like Medicaid is kind of not always integrated super, or from what I've heard, hasn't always integrated a ton with some of like the health promotion and like health equity things within the public health ecosystem. And I'm just curious if this will provide any opportunities for that, like looking at epidemiologists to work inside of this division and like look at various health indicators of this population, because it's just like a very complex population group that I'm just interested in how their health outcomes can improve from this type of integration.
Yeah, definitely. And I think a key part of this results-based accountability model that we're using overall is outcomes-based focused. And so it does lead us to those discussions of what things are we going to be watching to measure whether or not health equity is improving, whether or not health is improving of the individuals we're serving. And so a key part of that are these upcoming discussions we're having about which areas are we going to watch and which efforts are we going to undertake to help improve the health of individuals. We've had several with the upcoming discussions that will be going on with the One Utah Health Collaborative. There's a desire or a goal that all the entities participating in that group will have goals and items that they'll be working on related to that. Jen and I and others in the department have started some discussions about different efforts that we've been working on or are considering working on that would be able to improve the health of the members. Collaborative care, case management, pharmacy management are all things that we have talked about in those discussions. And I think those types of things might be things that we may be bringing forward as projects that we may be focusing on in the near future. And then we would use our metrics to see if we're making progress in those areas.
Cool, thank you. A quick follow-up is, is there in the way that this is being crafted, is there a place where like a public advocate, like a public advocate that can help to, like, let's say someone has like a negative experience navigating the healthcare system and they would help from the public sector in that? It's just something I hear a lot from people. It's just hard to know what to do with the grievances, and I've heard it, I always get different things said. So I'm just curious if that fits in that when you talked about customer experience and things like that, I'm just curious if that's a part of it.
Yeah, it's a really good question. And as I've moved to another part of the org chart, you can see in the operations section that we've proposed to create a unit for customer experience. You may also note that you can see the leadership who would direct that group and the subgroups has not been identified yet. This is an area that's still in development and in the department, and how fast we'll be able to move in this area is still part of what we're working through. But I see that this unit might be an area that might be able to help with that, to say, as an individual, here's what my experience has been. Here's where I felt like the process broke down for me. And part of that you may be able to come directly to the division and we may be able to help you with that issue. But my experience has been that there's often multiple entities involved in an individual circumstance. And so this customer experience unit might be able to help bridge and work across different organizations, different parts of the department, and be able to focus in on that customer experience. What does it look like when a member, tries to get services outside of the normal system or something like that? And what is their experience when that happens? And are there ways that we can provide additional information and give additional direction ahead of time that might be able to help prove that what happens with that member?
Cool, thank you so much. Does that include like the private sector? Will that include helping people understand how to advocate for themselves, inside of the hospitals or inside of the clinician patient perspective too? Or is that only for their experiences with the public sector?
That's a good question. That's probably more than what I've been thinking about it, but that's a really good question. As we develop that group, where might those types of things fit within the work that they're considering or doing?
Yeah, I'll just say, because it's happened quite a bit just over the last few months, that when when I've been approached by just like people who like don't know what to do, and they'll ask like, and if it's in the private sector, it's really hard to figure out like where to send them, and especially if like they're the parent of like a child that has complex care needs or whatever. It's just really hard to always know where to like, and it just becomes a spiral of trying to like find the right person. Anyway, it just has like happened multiple times, and I've just thought that it would be, I don't know. I was just curious about whether that was something that like could be a role that, you know, but I understand there's kind of it's just weird because it's a private, anyway, I just thought I'd bring it up, but I do think there's like a need for that, whether or not it fits in there or not. I just thought I would share. Thank you for your response.
Of course.
Andrew, your question?
Stephanie and Nate, I was just, you were having that conversation about potentially crossing the public and private boundary, and I was thinking it's just being developed now, but the vision for the disability ombudsman that's going to be part of DHHS is that it can at least provide information to individuals about both public and private services and support systems, and also provide information to private businesses about their obligations under the ADA and other federal and state disability laws. So that might be, since it's just being created, that might be a model you want to talk to those folks about and see if something similar, if a similar ombudsman position might address some of the concerns that Steph is talking about in related to the Medicaid experience specifically, but the healthcare experience in general. So.
Andrew, you hit on we were thinking along some similar lines when we decided where to put the ombuds offices, the ombuds individuals, those that are serve those roles, including the new one related to individuals with disabilities. And that's why one of the reasons why we are planning to put them in the customer experience unit, because we think that they can really help inform and are a key resource both to the public and to the department about what's going on, what people are seeing and experiencing, and how we may need to make changes to make that to help them navigate that system or to make it function better.
Okay, I have one more question just about the merger overall. You know, with everything that's been going on over the last couple of years, it's been really hard on a lot of employees, I imagine. And I'm wondering what, as this is wrapping up, because I think it's been a pretty quick timeline, it's been a big slog. What's being done around encouraging employee retention or to support our public sector workforce that has been merging and battling the pandemic. So I'm wondering if that, how much, what kind of conversations how intentional this is into the planning of the merger as it moves forward too.
Yeah, it's a really good question. The health and welfare of our employees is a huge issue, and it is for all employers right now, but also each individual area sort of has its unique stress. And as we look at health and human services, being frontline on the COVID response for the last couple of years has drained and really required a lot of certain parts of our team. Other parts of our team have been running institutions, running the developmental center, running the state hospital, running juvenile justice programs through, having these residents there 24/7 during the middle of a pandemic where congregate care is always a potential risk when you have a transmittable virus. So there's large parts of our teams that have been under a lot of stress for 2 years. And then you put on top of that all of the stress of a merger, which some people had to move offices. We're all adopting to new leadership, different reporting roles. The health and well-being of our staff have really been a high priority. A couple of things that we're doing related to that. We've instituted a process from the Guarding Minds institution where there's a series of surveys or a process of surveying where we do these little quick check-ins with staff, just a couple questions that gets the pulse of where things are going in the organization and allows us to compare over time where different units are and where our organization is overall about whether or not they're feeling their work-life balance is going, whether or not they feel like they're appropriately supported in their work. Overall, those results, we just did one last month, maybe for both health and human services for the first time. We were slightly below sort of the midpoint would say that you're about equally balanced as far as being good in this area or having some severe problems. And both of our organizations scored a little bit below that midpoint balance, indicating that there's, although we're not in, for most areas, not in the severe risk related to this area, that there are serious risks related to our employees because of the strain that they've been going through. And so we will continue to monitor that and use that as a way to help gauge individual areas balance right now related to this. And then specific efforts that we're taking related to that. The governor thankfully authorized 4 hours of admin leave for mental health issues for all state employees. So that gives a little bit of a bump. We've talked very specifically to our staff about the fact that they do get sick leave as they work as a state employee. And that while some may have thought of like house sick leave in a historical factor of saying, well, that's if I get sick and I have a cough, but we also need to remember that our mental health is part of our well-being too. And so that mental health issues can be covered by that sick leave. And so reminding them that they have access to that benefit to help them address their mental health issues. We're also have heard that some employees have struggled to get to some of the employee support we have, which would be like counselors and those things. And so we're working with our employee support program to actually have one of their counselors, we're hiring them, they're going to come in on site. So for those employees who are working in the buildings, we'll have an on-site resource available that they could go to and have access to that. And we're also considering developing peer groups where individuals would be able to go talk to someone else that's also a state employee to work through some of the issues that they may be facing related to the merger or other issues, and to be able to do that. So those are just some of the things that we're doing, trying to address the health and well-being of our employees.
Thank you.
Do you want me to just talk real briefly about infant formula? As we've all been watching that unfold across the nation, our leadership team has been working to try to see where the state can help in any way possible related to that. We do have a direct responsibility for some of these issues, one of them being WIC. And the state early on, several months ago, applied for a variety of waivers in the WIC program that allowed them to expand the types of formula being offered. Traditionally, the WIC program, due to contracting issues, is usually only offering a sort of a line of line of formulas available. Utah was early getting in and getting those waivers approved so that individuals could substitute equivalent formulas and really open up that ability to do that. So that was helpful, but as if any of you have gone and looked for formula recently, it doesn't really matter which brand you're looking for. There are often all of them, either many of them or all of them are out of stock. We are hearing, and we've seen, and as we've gone out and done some of our observations, that some of the basic formulas that are not specialized, those are available in some locations some of the time. But as we look at some of the more specialized, like for preemies and those things, that some of those other formulas are where there's some real struggles going on. We are looking with encouragement as the federal government's working on the ability to bring in foreign produced formula. There's promises and expectations that domestic producers will be able to bring back some of their production. And so there are commitments or promises from the federal government that they're expecting that some of these situations will turn around in the near future. However, our confidence that this will be able to happen has been somewhat hampered by the COVID response, where we've seen on a repeated basis where national shortages are not resolved as quickly as we would hope or expect. And although we hope that things are better here with the formula, we're also still trying to find other alternatives. We have been posting from our social media site, from our Twitter account, information related for parents to talk about what they should and should not be doing as they're trying to navigate this. We're also looking at other options to see, again, if there's other things that the state might be able to do. And also connecting with providers. Some providers have received samples of the different formulas and may not be using that. And so we're trying to find the best way to be able to redirect that if there are any significant supplies of unused samples. And so a lot of communication going on there. We're trying to make sure those messages are getting out to the public and trying to identify if there's anything that the state can do to help ease the burden on parents right now as they're trying to find those formulas. So that's all I have.
Thank you. Thanks for that. Is there anything specific going out to Medicaid members? I know there's overlap with WIC, but is there anything there?
There hasn't been any specific message. And Jen, maybe you can talk a little bit more about any thoughts about the best way to use some of this messaging that we're putting out on a statewide, if there's a way that might be more helpful to share to Medicaid members specifically. I know there has been communication to WIC members, and as you mentioned, there is significant overlap across those programs.
Stephanie, you want to go ahead?
Yeah, and sorry if I missed this. My phone cut out for a second, but are there like social media campaigns like promoting like and targeting certain demographics or like working with different people that like have a large audience on social media in Utah? Like I just like that's where I've seen like the most frustration about it, is like people talking about it on a lot of my friends. That's how they're trying to find it, is like through crowdsourcing on there. So I'm just curious if y'all have like looked into options for like communication strategies from that angle.
As we do social media campaigns, we often consider whether or not different influencers would be helpful in promoting this message, any given message. As we're talking about what's going on with formula, we really haven't moved this into sort of the concept of a campaign or reaching out. So we're relying on our traditional social media outlets right now to get that information out. But to the extent that this extends and we think there might be an opportunity, that is something we usually look at to see if there's some advantage to doing that. And if we have the right connections with the right people to do that.
Thanks, Nate.
You're welcome.
Well, yeah, thanks for coming by virtually, and you're welcome to stay, but yeah, if there's any other questions, we'll also make sure to get them your way too.
Okay, sounds great.
Great, thanks. Jen, you're up with the director's report. Oh, actually, sorry, UTA passes. We can do it all.
Yeah, thank you. I'll start first. Stephanie, I want to follow up with a question that you presented earlier on around accessing some of the treatments for COVID. And I will make sure you have the opportunity to see these links. There's been quite a bit of effort put into making sure treatments, here you see this landing page with COVID-19 treatments underneath the coronavirus.utah.gov with a list of various hyperlinks here. And I just kind of open these links. If you go through under the providers tab, so if you were to go down through here under the providers tab, there's a specific link on Therapeutics Locator. And from this, the Therapeutics Locator tab, you can actually narrow down your search. So this is sort of a national query, and you go state specific. So I was able to research Utah, and then you can go by therapeutic choice. So selector here with therapeutic selector. Stephanie, specific to your question, I did click on Paxlovid. So it would query the number of doses of Paxlovid, which we see in the state of Utah. There are 4,162 doses available. It updates across here, as you can see. It gives an image here of these locations across the state. And then specifically here, it also lists addresses and available stores to get these as well. There is also a downloadable, sorry, I didn't want to mess with this too much while I was on the line with you all. So there's also a downloadable report that you can get from this site that allows you to see the sites with Paxlovid. This was updated on March 2nd. These are facilities that do carry and are authorized, distributors of these products. So these resources are available. I will connect this hyperlink into the chat right now, so you have that. But this is, run by the Department of Health and the task force that's working on this. I'm myself didn't have this ready at my fingertips when you asked the question, so I needed to make sure we could get this and show this to you. Does this answer your question, Stephanie, on ways that individuals could find and locate medicines, and then the specific medicine, and then the providers and where they're located across the state?
Yeah, thank you. I will definitely use this. I do worry about how many, I think it will help some people who help people. I think some people just don't always want, it's just it's hard to keep looking for things, but I do think this is helpful. The other thing I've heard a lot of confusion about is if people need a prescription. And so I've heard people say you just have to go through, I don't know. I've just heard a lot of mixed things about how people can access it from the prescription side, but I believe that's also covered maybe on the website.
It is, and I actually am just asking Brian to put in the hotline phone number, so I'll have him research that while I go through the UTA update. There is a hotline that members can call to help access these services, and these are individuals trained to help coordinate Medicaid members with services like this, because it can be confusing to kind of move through the different web pages to find exactly what you're looking for. So I'll make sure we get that loaded into the chat. And so Brian just put it in here, Stephanie. So please give any feedback you have on this. If you have additional questions, we're happy to take them. But these are statewide resources. I know this phone number too was meant to help individuals access these resources so that they could do exactly what you're saying. Like if I'm COVID positive, where can I then get a prescription, and then how do I, get a prescription written, and then where can I get that prescription filled? And this is meant to connect that to them. So, and as far as the prescriptions being mailed to them, I can't answer that question, but I can certainly research that question for you.
Thank you. I appreciate it.
Yeah, you're welcome. Okay, the next update, this is several pages, which I'll be happy to share with you as a follow-up resource item following this meeting. But I was asked to give an update on our Utah Transit Authority card update and the policy changes, not really the policy, but the program changes that are going in place on July 1st. So as just a background on this, Utah Transit Authority has been allowing Medicaid to use a paper punch pass card for many, many years. These passes are distributed by DWS on a monthly basis to identified Medicaid members who qualify for the services. On July of this year, the paper card will go away and it will be replaced with a digital tap card. And so this is more familiar with maybe a UTA card you and I may have used or have seen, where it's kind of a laminated card. This is not a 1 month card. This is meant to be held by the member and used month over month as long as they maintain their eligibility with Medicaid. That card will work for them to receive UTA services for medical transportation as part of their Medicaid benefit. I've covered quite a bit of this in the past, but was asked just to give some updates to the policy with you today. So I'd like to just cover some of the communications that have been sent, as well as some updates to the program. So first, we have a member communication that is being sent out with this month's paper cards. So every month the cards go out around the 20th or so of the month. When benefit issuance goes out, the paper punch cards will go out right around that time frame. This month, we are putting a UTA bus pass update insert into this month's paper UTA card mailing. And an image of what this looks like is right here. And so this will be included as an insert into the paper UTA card this month to alert members who are receiving this that this is changing. The next piece we wanted to update you on is that the digital cards have been ordered. We ordered 25,000 cards up front. We're ordering an additional 25,000 to continue fulfillment of requests for cards that we have. There are 20,000 regular cards and 5,000 attendant cards that will arrive in early June. We have a mailing campaign that is going to happen where these will be the communication and additional communication and FAQ that answers questions around these cards, as well as a new card that will be assigned to members who receive existing UTA passes. They will auto be mailed this new UTA card. Households that have multiple members receiving cards will receive multiple mailings. In order to reduce confusion around whose card is assigned to who, we want to make sure that when the mailing is sent out, the individual whose card that is assigned to will receive a unique mailing. So that will happen in late June, and certainly in our June MAC meeting, we can update you on that process. Additionally, the My Benefits platform will be the tool that we use on both sides to have members access this platform to see if they qualify for a UTA card. So there's a short questionnaire when they log in to their My Benefits platform that will run through a couple series of questions, asking things like, whether or not they own or have access to a personal vehicle, for example, is one of our questions. And they will work through that in order to order a card. Additionally, the member would log in to order replacement cards or additional cards, as well as guardian cards if they need that for if it's a child and they need a guardian card for the parent. Additionally, attendant cards can be ordered through this as well. So on our side, our health program representatives will also, if they receive incoming phone calls from individuals, from members who are asking about UTA cards and have questions and may not be using the My Benefits platform from their side, the health program representatives are also able to access the My Benefits platform from the administrative side and are able to request cards and manage cards on the back end for member requests as well. Are there any additional questions? I saw. Any additional questions beyond on this particular information? Okay, and a question came in that on our paper card, right now on the paper card, individuals are authorized to have 12 rides per month. So the card has 12 stamps on it, and the driver is meant to kind of punch the stamp each time a member would ride on UTA. And this card will, since it's a digital card, will have a use amount on the inside embedded in the digital card. And we have our policy will allow 30 rides per month per member. Another question that came up that I want to provide clarification for, Stephanie, you asked a question around transportation to the pharmacy. And the question around the pharmacy and that limitation was not specific to Medicaid policy. So I wanted to clarify that Medicaid policy is not specific to the use of medical transportation and any MT services to the pharmacy. So UTA services are allowed and under Medicaid policy to be used for an individual or member to go to the pharmacy to pick up a prescription. The specifics around pharmacies was actually an element that is in our Logisticare contract, that there is a limitation around the Logisticare driver taking a member to a pharmacy specifically under the current contract that exists with Logisticare. Because of the number of questions that we have had around this, it's certainly this Logisticare or Motive Care contract right now is up for RFP. And within the RFP requirements documents, we're modifying that section to allow rides and transportation to the pharmacy within a new NEMT Motive Care contract. But that is not a specific Medicaid requirement. So I want to make sure that addresses a question, Stephanie, that you had brought up last time around trips to the pharmacy.
Awesome, that's great to hear. Thanks, Jennifer.
You're welcome. Jennifer, did you have a specific question? I saw you came off of mute, or did I answer it?
Yes, you did answer it. Thank you.
You're welcome. Okay, and then just to be complete, we are putting out a May MIB, Medicaid Information Bulletin, with a write-up around our UTA past changes. And so the content is here. I will make sure this information is shared, but this is being released with our May MIB, which will go out this week. So, any additional questions on the UTA process? Okay, thank you. So next on the list is an update on our housing-related support services policy that I wanted to give an update, and I have members of the Medicaid team here available also if there are additional questions or more detail needed. So there are some updates with this. First of all, we have received CMS approval. I think we mentioned that last meeting on this. So that is good. The second update is that we did have to put programming changes in our system to authorize these services and allow them to be available and billable services for Medicaid providers. And these system changes have been programmed and are ready to go. We are working on the rates. So when the policy has been developed and is ready, our systems have been updated to support the policy. The third element is that we have been interviewing staff members to help facilitate and support this service. And those interviews are going on right now, even today. So that process on hiring the staff members is in place. And the fourth thing is our policy manual, which supports, again, the housing-related services, has been drafted. We anticipate that it will be published with our July mid-cycle. And so the draft policy is just about done, and it would be published in the next month or so. And then we believe all of the pieces can be in place to go live shortly after that. Are there any other specific questions? Or Joseph, I don't know if Tanya dropped off, if there's some extra details you'd like to share on this policy.
I'm still there, but you covered it. Oh, Joe, go ahead. Sorry.
I think I was going to say the same thing, but I think you covered the big items, Jen.
Okay. Does the committee or other individuals have additional questions about this? Okay, great, thank you. Okay, several other items of policy development are in the works, which I'd like to just bring to your attention. First is an update to our CLIA billing. A letter was sent to approximately 2,200 letters were sent to different labs to update our laboratory providers, Medicaid providers, on the fact that our system has been updated while each lab has a CLIA billing code to put on their claims when they're billed. And our system has been allowing some claims to process without that, with the CLIA code on it. And the system has been updated to require that effective July 1. So we sent a communication out to our laboratory providers. While they all had been registered with their CLIA number as a Medicaid provider, sometimes it was being left off the claim. So we sent out a notice of that, and that is also included in our most recent MIB update to alert our providers of that programming change. There has also been a notice that has gone out for our EVV program, and that specifically looks at, and I'm actually noticing I closed down a letter, but a letter was sent to our home health providers letting them know about the EVV requirements that are mandated to be in place by January 1st of 2023. And this notice was meant to have providers complete a survey and make sure they were meeting the standards to be EVV providers and meet the requirements to be enrolled in that program, so that effective January 1st, we're able to meet our federal requirements in that. The third thing I wanted to touch on is there's several items that have come out of session that are being worked on and are ready in our system for July 1st. The first was equal reimbursement rates for autism. This is effective July 1st, but there was a 34% increase across all of our autism codes that was applied for ABA-related services, and that's effective on July 1. There was also a 20% increase in the methadone dispensing daily, the daily dispensing fee that's given to methadone providers. And so that has also been implemented for July 1st. We have changes that were put forth on our coverage of porcelain crowns for our EPSDT and pregnant populations, and this is also in place for our dental programs. Additionally, we have opened coverage for resin-based fillings for posterior teeth. So these are white fillings instead of the silver mercury-based fillings. And previously we had covered the resin or the white filling on the front teeth, but not the back teeth. And the codes for resin-based fillings have been opened for EPSDT individuals and pregnant individuals, I guess all individuals on effective July 1st, to address some of the safety concerns if you're using those mercury-based fillings in the teeth. Additionally, there has been significant work done around our Hcbs waivers. There are 9 waivers that have been updated and are being updated to reflect some of the rate adjustments that came through legislative session. So those are also in the works to be implemented on July 1st. Also, we have 2 different policy changes, one around the diabetes prevention program, and second is our medication therapy management program. So both of these policies are in their final draft phases. I will bring those to the next MCAC meeting for presentation, more thorough presentation to the committee. Are there any questions on the policy updates that were presented? Okay, I know that updates to the SPA were included in our materials that were sent out. I would like to highlight our coverage of COVID medications for our COVID uninsured group. So this was coverage that was open for our COVID uninsured population for both vaccinations as well as medications for the treatment of COVID. These were retro opened back to March 1st, 2022, and will be open through the last day of the public health emergency. So that information also went out in a Medicaid information bulletin. It was faxed to all of our pharmacies as well, and also was submitted to CMS for a SPA update. So you saw that reflected in the SPA materials that were distributed. There is also, I'll just highlight one additional, at a very high level, we are updating all of our state plan amendment documents as well to reflect our organizational change of moving to the Department of Health and Human Services. So a number of changes are being put in place to reflect the organizational update. And so those will be in process as well. We're also continuing to review our rules to align with the governor's standards. So you see a number of rules that have been put through to reflect some of these standards So are there any additional questions around rules or SPA changes? Yes, Rachel.
Hi, so I'm going to try and explain this one as best as I can, but it's kind of wordy. So Ouch actually had a rule or a question about one of the CHIP rules that was released in, I believe on the 15th. And it was basically removing language that what was considered non-emergent medical care. And it removed the language that was basically using a prudent layperson standard reasonably believes, and that part was removed, that the child was experiencing a medical or emergency medical condition. We're kind of worried, and you might be able to just clear this up, that this might put a burden on some CHIP beneficiaries to kind of know when their child is actually having that emergency medical definition as defined in Malta before they're actually seeking care. And the only exception that we see to that non-emergent medical care is it covering screening, but it doesn't, that language doesn't explicitly cover any type of care that would happen afterwards. So it's kind of like a little bit of a technical question. I hope that made sense. And then we also have concerns about what is defined as emergency medical condition under in Malta as well. It is a little bit limited. So we're just kind of worried about that, like, prudent layperson standard reasonably believes being removed.
Yeah. Thank you, Rachel, for the feedback in your review actually of the updates to that rule. Would you mind putting your the both of the items that you mentioned here, would you mind sending both myself and Jeff Nelson, who is our CHIP director of communication, on these so we can evaluate your request? Okay.
Yep. Thank you. I appreciate that.
You're welcome. Go ahead, Jesse.
I also have a question about the other CHIP rule, and I don't know that, I just wanted to get a little bit more detail around electronic personal medical records for the CHIP program. What are the updates and changes that are happening to that piece? And that's the rule.
Yeah, I'm kind of looking at Jeff. Jeff, are you? Able to take this question?
Sorry, yeah, I am here. Sorry, can you repeat the question, Jesse? I'm sorry.
Oh yeah, no worries. I'm also just curious about the new rule change, the electronic personal medical records for the health insurance program. And it says it's to update and clarify, but I was wondering what the updates and clarifications are for electronic personal records for CHIP.
Yeah, so sorry about that. Being in the building is one of the fun things about being here is that the internet is never great, and so it's pausing out as you were saying those words. I'm struggling hearing you. I'm so sorry.
Oh, that's okay. I was just wondering about the rule around electronic personal records for CHIP, the rule change.
Oh yeah, that's one actually that I'm not familiar with as well. We can get more information for you. I'm happy to provide an answer maybe next time we meet on that one if that's okay. I'd be happy to bring that back.
So,
Go ahead, Brian.
Jesse, thanks for the question. So the changes are specifically related to rule writing manual updates. So it is just technical changes, no policy changes in it. It is things like rewording how we define program website, rewording sentences instead of the CHI, which I think you're familiar with, Clinical Health Information Exchange. Instead of saying will enrolls, it's CHI enrolls. It's just to bring it in compliance with the rule and making manual, no policy updates in this.
Great, thank you.
Thanks.
And Brian, I'm wondering too, I mean, just this is related to an executive order that the governor issued some time ago for all state agencies to bring their administrative rules into compliance with that rulemaking manual. So that's why all agencies are going through and just doing language cleanup.
Yes, a very good point. Yep.
Okay, any additional questions? Jeff, do you have anything to report on the CHIP outreach update?
I don't have anything new to report right now, other than we have, so Colby has been working very much on getting the group together. We have hired our intern, Jorge, who's helping out to get things moving there, but nothing new to report at this point.
Colby.
I have a quick update if you want, like a comprehensive overview of the activities we've been doing, or is what Jeff provided sufficient?
Colby, if you'd like to cover the activities that are being done through the outreach efforts, that would be.
You want me to do that now? I can absolutely do that.
I think Jesse, is that okay if we take a little bit of time to do this? Okay, thank you.
And I don't remember, I think I've presented to the CHIP Act, but I don't know if I've presented to the MAC. In 2021, the legislature appropriated funding in HB 262 specifically for the children's outreach for CHIP and the children's Medicaid program. So we have contracted with an advertising vendor to do a campaign for the programs, as well as hired a new outreach specialist who's able to help with kind of facilitating that from our agency. They have, since January 1, when the campaign launched, we have done both social media and traditional outreach and advertising through Google, Facebook, Instagram, Bing, YouTube. We've done pre-roll, streaming ads, and then traditional radio and TV and billboard. So through that, I only have data and metrics through April 30th. So from January 1st to April 30th, we've had more than 45 million total impressions, 20,000 clicks, and more than 700 calls. Just in the last month of May, so the 1st through the 18th, we've had 5.5 million impressions and like 3,500 clicks. So we're seeing that people are seeing the ads and are watching those metrics. We've had billboards, both static and rotating digital billboards, and we've identified locations based on uninsured data collected through IBIS. We created the new Covering Kids landing page, so it has information about both programs, both CHIP and the Children's Medicaid program, and we have that available in English and Spanish. And I will mention that all the ads are in both English and Spanish, so we are running campaigns in both languages. And then we've created 2 digital videos for both English and Spanish that are available on the web page and have been used in the social media advertising. So in addition to kind of the advertising efforts that we've enlisted in, we've got some sponsorships going on. We have a sponsorship with Real Salt Lake, and that includes both, let's see, pre-game ads, show sponsor mentions during breaks, 108 in-game commercials, and then weekday commercials, as well as a table at all the games with information, and then it will include all the games April through July. So that's one sponsorship that we felt would target specifically the Latino community, because that was an area that we wanted to try and specifically reach. We've done a targeted zip code mailing to 32,000 households with using 25 zip codes at the highest percentage of qualifying households. So zip codes that are more likely to have eligible individuals. We've partnered with U92 to participate in some promotional events like the Valley Fair Mall Easter egg hunt. We have a booth there. We have commercials leading up to the event. We did the Cinco de Mayo events that they had, and then we'll be doing a summer community event through them. So while we worked with U92 for English radio, we've also worked with Alpha Media, which is the Latin radio entity, and we will be doing events at their Festival Latino Americano, and then a health festival in October, and that will include, again, on-air pre-recorded promotions, commercials, streaming, and a booth. Couple more things. I know this is a lot. We've been able to be featured on the Good for Kids segment on the Daily Dish. So we've been able to sit down with the host of that show. I participated. We had someone from Take Care Utah. We had the current and former CHPAC chairs who sat down at different times in the last 3 months and talked about the programs and the benefits of having health insurance and the availability of these programs for families who qualify. And then finally, we have done some community partnership activities, which we've worked with school districts, rec centers, food banks, all those type of community entities, and sent them a letter, some suggested social media posts that they can post to their accounts to get the word out to their audiences, and then an electronic flyer. And then we also did that with the Chambers of Commerce, asking them to help spread the word to businesses and employers about health insurance options available for families. So to date, that's kind of a summary of all the things that we've been doing. I don't have comprehensive data collected at this point. We'll do that at the end of the campaign, and I can provide an update at that point. But just so you know, there's a lot going on in promoting these programs at this time. Did I see a hand?
That was me, Colby.
Okay.
Thank you so much for that update. I had a question about I know we've talked a little bit about, but in HB 262, I mean, this is really exciting. Thank you for sharing the update. It's great to see that there's CHIP outreach happening. So I had a question in HB 262. There was also a section around conducting research regarding families who are eligible for Medicaid and CHIP to determine awareness and understanding of available coverage, analyze trends in disenrollment, identify reasons that families may not be renewing enrollment, including any barriers in the process of renewing enrollment, administer surveys to recently enrolled CHIP and children's Medicaid enrollees to identify how the enrollees learned about coverage and any barriers during the application process. Do you know what's the status of that piece?
Yep. We are in the middle of trying to get that launched. So we have a disenrollment survey drafted. We have all of the participant emails gathered. We are just trying to work with a contractor to get that off the ground, and then they will go ahead and do the analysis that we can provide at a later point. But yes, that is absolutely in the works. Now, to clarify, we're only doing CHIP families because we have not been doing traditional renewals for Medicaid families, right? So the value at this point is really for CHIP families who have are no longer on the program and understanding why they're no longer enrolled.
One thing that I know has come up before too, and I don't know if Nate is still on the call either, but to see if there might be the opportunity to, in addition to the disenrollment, to look at the enrollment process and like do a usability assessment. And there was some talk during a couple months ago that maybe there was the potential for Qualtrics to get involved. I didn't know if there was any update on that. It been floated before, but looking to see like how family or how a parent goes through the enrollment process when they're online and like places they might get stuck, sort of looking at the online application and assessing its user friendliness and where people might be having problems. Do you know any updates about that piece of this?
I haven't heard that specifically, so I'd have to defer to somebody else in that conversation.
I'm looking to see if Nate.
Yeah,
Oh, he is. No, he's.
I think Nate left, Jesse, and I'm happy to take the question back. But just, and I know he'll be familiar with this, but the question was it watching someone with an online application to be able to assess where there's challenges or difficulties as you're observing the process and identifying places where an individual may kind of encounter some difficulties with the online process. Was that sort of the basis?
Yeah, and I noticed at some point that might have been part of the conversation, or like part of the research that could be conducted. So I just wanted to see if there was still that possibility.
I'm happy to follow up on that item. And I'd invite Emma, if you have any information on that, I just welcome any updates you may have had on that conversation from the past.
I don't have anything on that.
Okay.
Jen, I'm wondering if, Jesse, did that also come out of the discussion that I think you and maybe Jeff and Representative Dunnigan were involved into around the length and the difficulty of even the application, even the paper application? I'm not sure if some of that came out of that discussion as well.
It was mentioned then, yeah.
Okay. Yeah, I don't have anything more, Jen, on that.
Yeah, that's great. Thank you, Emma. And Jesse, I'll follow up with that, okay?
Thanks. And thanks, Colby, for updates on both of those pieces. It's exciting. Oh, and there was a question in the chat, I don't know if you saw it, Colby, around whether or not you're involving churches in the outreach effort.
We did a significant amount of community partnerships, and I know there was a broad list of different organizations within the state, but I don't know specifically if churches were targeted. So I'd have to go back and look and see who was included in that. Is that a suggestion? I'm guessing.
Yeah, I think it's a good idea. I mean, but if others disagree, but I think that churches, I've seen lots of campaigns that work to get people signed up at church.
Great.
Thanks, Colby. Jen, does that conclude the director's update that you have?
It does. Thank you.
Okay. Actually, I have a quick question before. So I was going to make an announcement as a reminder to everyone that our June meeting is going to be from 4 to 6 because this is when we'll be presenting budget requests. I guess my one question is, are we doing the traditional route given the mergers? Anything changing in terms of how building block? Like, should we do anything different on our end? But we can also send out information afterwards. But that's just a question. I know we're kind of tight on time, but I didn't know if there was anything to think about there. But also, everyone who's still here, remember 4 to 6 is our meeting in June, because it is the budget presentations. So if you have any, please send them to Sharon, and just remember that we will be showing up at a different time over Google Meet instead of the usual 2 to 4 p.m. So 4 to 6 in June. But back to my question. Jen, is there
Jesse, I can respond to that just a little bit. We just began our budget prep process this week as a healthcare administration section. So as we go through our discussions and how that would impact the role of the MAC and what we bring to the MAC, we'll let you know in advance, and we can talk about it at the preparation meeting if that's okay.
That sounds great. Yeah.
Yeah.
And we'll just plan to proceed as normal, but if there's anything you need differently, we'll be on the lookout for an email. But
that's great.
Great. Okay. Thank you. All right. Well, I think with that concludes the meeting. Reminder, 4 o'clock in June, not 2 o'clock. 4 to 6 p.m. is our meeting in June. And I have to say it many times, otherwise I'll forget. So hopefully everybody's got it in their brains too. And thank you everybody for showing up today and for the discussion and all the great information that's been shared. And look forward to seeing everybody 4 o'clock in June. Thanks again. Have a good evening. Bye.
Thanks, everyone.
Thank you.